Rebecca.
Chelsea. Thanks for hosting as always.
Yeah, no problem.
I see we have a few people joining us. Welcome. Thanks for coming today. We'll be getting started in just a few moments. See, we have a few more people trickling in. Again, welcome. Thank you for coming. We do encourage you to introduce yourselves in the chat. Just scroll down and select everyone. We like to get acquainted with who's here today. But we'll be getting started in just a moment. Thank you. Welcome. Thank you for coming, everyone. We'll be getting started in just a moment. Thank you for your patience. There's Dr. Reinblatt now. Hello, Dr. Reinblatt. How are you today?
Good. How are you?
Doing well. We've already got a few people on joining us today, so you
Excellent.
can probably go ahead and jump in if you want to pull up your slides.
Okay.
And thank you again, everyone, for joining us. We're going to be getting started here in just a moment. In the meantime, please do introduce yourselves in the chat so we can get acquainted. Just scroll down and select everyone when you want to use the chat function.
So,
Is it allowing you to share your screen?
it is, there's an issue with the new slides, the new format. So I was just texting Chelsea to see like what to do.
Okay.
I have the original version that I sent, the slightly, older one.
We can go with that one if that's
Okay. Okay,
better.
I have that one up and it's working.
Okay.
So, well, I think it's working. I don't want to jinx anything. Hold on. Okay, let me share. Let's see. Share screen. Let me make sure this is up here. And then, All right, here we go. Share screen. Sorry, it's slightly different than Zoom. I'm
No,
very
that's okay.
Zoomified.
Yes.
Okay, share. Can you see that now?
Yeah, we'll just need to put it in the
Yeah,
presenter
yeah.
mode.
Yeah, here. Does that work?
Yep, that works. Thank you.
And
So
can
I'll
you
just
hear me okay?
Yes, I can hear you.
Okay.
I'll just start out by introducing you. And my name is Rebecca Farah. I'm a part of the BHIPP team. I'll be facilitating the Q&A at the end of the session after I do a brief introduction first. And at the end of the session, we will have some time for questions, so please do enter these into the chat when the time comes. For those of you that are unfamiliar with BHIPP, I would like to provide some information about our program. Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, care coordination, and training and educational opportunities. The BHIPP Warm Line is staffed by a team of child and mental health specialists and is available Monday through Friday, 9 a.m. to 5 p.m. And our phone number and website will be placed in the chat for you so you can learn more about our services. It is my pleasure today to introduce today's BHIPP Resilience Break, Addressing Picky and Disordered Eating in Young Children Within Primary Care, presented by Dr. Shauna Reinblatt. If you want to advance the slides, we'll look at your bio real quick as I introduce you.
Oh, sure.
Dr. Reinblatt is a clinical assistant professor at the University of Maryland School of Medicine, Department of Psychiatry, Division of Child and Adolescent Psychiatry. She is board certified in general adult, child and adolescent, and consultation liaison psychiatry. Prior to her becoming a psychiatrist, Dr. Reinblatt worked as a family doctor in Canada. She was a member of the full-time faculty at Johns Hopkins University School of Medicine in the Department of Psychiatry for over a decade, and during this time she developed specialized clinical expertise working with children, adolescents, and adults with eating disorders, in addition to her clinical child psychiatric work with youth. And Dr. Reinblatt is also a BHIPP consultant, so you may interact with her during consultation. But with that, thank you so much for sharing your expertise today, and go ahead and take it away, Dr. Reinblatt.
Thanks, Rebecca. Can you hear me? Okay? You can hear me, right?
Yep.
Okay. All right. So, how fitting that we're talking about picky and disordered eating over lunchtime. So I hope I'm not disturbing anyone's lunch. I actually had my my daughter, in the interest of full disclosures, I have no disclosures, but my daughter actually made that picture that's up there, the stick figure, and the very detailed Haagen-Dazs ice cream and pizza, which are her two favorite foods. So hopefully that whets your appetite for lunch, that hopefully I'm not disturbing. So I'm going to be covering, we're going to go over picky eating, which by definition is usually in younger children anyway, but to identify some clinical features, and then move on to Arfid, avoidant restrictive food intake disorder, and then touch on, you know, some general principles of management, whatever we do kind of know. And so let's start with picky eating. So here is Ashley, fictional Ashley, 3-year-old who loves attending. She's actually a little more than 3 years old, but anyway, loves attending preschool. She likes seeing her friends. She likes to play games with them. She's a little bit, you know, she likes to direct the games. She doesn't eat any of the food provided, and keeps saying, no, I'll eat later, I'll eat later, I'll eat at home. But then when she gets home, her mom tries to feed her, and she also doesn't want to eat most of what her mom tries to feed her. She's very particular. She definitely doesn't eat leafy greens. And her mom has tried unsuccessfully to present her with several new foods. Kudos to mom. Unfortunately, it was unsuccessful most of the time. She's met her developmental milestones as expected. She's growing well. She's following her growth curves, and she really has no significant either medical or psychiatric history, nor any symptoms that are of concern. Okay, so our picky eater, Ashley, let me see. Why is it not? Okay. So, So let's talk about picky eating. Some people call it fussy or selective eating. Certainly, as we'll talk about in a bit, this has been around for quite some time, obviously. Developmentally, I mean, primary care and pediatricians, you all know about this probably way better than I do. But developmentally, it's a normal phase from about 18 months to age, sorry for the typo, 3 to 4 years, maybe even up to 6. But mostly the younger kids, like the preschoolers and the toddlers who, you know, come off eating a lot, increasing their weight, and then develop these strong food preferences. Some of it's kind of their independence and separation and stuff like that. And some of it's just maybe their taste changes, but they reject novel food. They like to have more of a control over what they eat. But importantly, it does not affect their growth. They're not underweight. They don't need supplements. And although they may have tantrums when, like we talked about for the case of Ashley, may have tantrums when mom tries to present new foods, there's no, you know, major psychiatric symptoms, like no mental health concerns, no physical symptoms either, no medical issues, and they function well, basically, with their peers. There's no decrease in psychosocial function. There's no sensory, there shouldn't be major sensory symptoms for sensory sensitivity, and there shouldn't be a fear of choking or other fears about eating, really. So, sorry. Okay, so here is, I'm going to play you a snippet on YouTube that really well describes this.
Pick up me the red Reese's Pops, because I only like the red ones. Orange and purple are good too. But red tastes better. Help me put away the groceries. Then you can have a red Freezy Pop. Ugh, gross! It's looking at me! You're not gonna feed us a dead fish, are you? You've eaten fish before? Well, it's never looked at me before. DW scared of a fishy. I am not scared. Fish smells funny, and I hate food that smells funny. These green eyeballs? No, they're olives, and they're not looking at you. Cucumbers, yucky. Tomatoes, yucky. Peanut butter. Jelly, yummy. My bread. Yeah, yucky crust. My sister DW is what you might call a picky eater. Yuck! Spinach! I hate spinach. Spinach is the worst, most disgustingest food in the universe.
Okay, so that was from Arthur. I'm sure a lot of you are familiar. If I can just move off the slide now. Okay, so that was, you know, pretty typical. She was talking about how she likes the bread, and in the next second says, "Ooh, yucky crust." So I think we've all had patients, and I've had family members like that as well. So the prevalence of picky eating is very variable. In the old days, a lot of this research was under like feeding disorders, and you know, with DSM, as we'll talk about, the nomenclature's advanced, and so a lot of these overlap with the new, you know, this is sort of an umbrella term. But what I'm trying to talk about here is not the Arfid group of kids, which we'll get to in a minute, but just the picky, developmentally kind of appropriate, or maybe a little bit more than that, sort of the mild to moderate group. And it's such a variable prevalence, 8 to 50%. So it depends on where they're looking for these kids. If they're looking in, like, you know, specialty clinics, or, you know, just in primary care. They did a prospective study of 120 youth up to age 11. This was back in 2010, and they found a point prevalence 13 to 22% prevalence at any given age. 40% of them only lasted about 2 years, and then the incidence or the new cases declined, and lots of tantrums and struggles around eating. And the kids who tended to be more severe in terms of their stronger food dislikes and having a less of a variety of food. They call it, you know, it was sort of more of a trait-like, and by that I mean it was sort of more of a chronic issue. A large population-based study done in 2015, published in the International Journal of Eating Disorders by Cardona Cano, found prevalence that was higher as we'd expect at, you know, a year and a half, and then as we progressed towards 6 years, went from 27% initially down to 13%, and only 4% of the sample had an onset of these picky eating symptoms at 6 years or over. And so, you know, generally we try to present new foods, or we, you know, tell our families to, you know, continue to present new foods. It's really, really common, as you all know. It may take 10 to 15 times of presenting new items for children to finally try it. You know, when for those children who are more resistant, and even those who are less resistant, using positive rewards for positive behaviors, presenting new foods. I pulled up here, you can see there's a dinner plate. There's lots of new items out there that kind of help with this. You know, you start and then it says yummy, good job, keep it up, you know. So and then at the finish you can put like a, you know, the reward, whatever it is, whether it's food or not. You know, decreasing the attention for negative behavior. So if there's tantrums and lots of outbursts, trying not to give that as much attention as when they do something that you want them to do, such as eating food off this plate, for example. Hopefully the foods that you're trying to target, like vegetables and new foods. So mealtime exposures is what we're talking about. And to establish routine meal times, often eating as a family or as a group, and spacing out your meals so that you're not trying to feed a child who's particularly full, like just had snack, and then you're getting into a power struggle. So leaving like 2 hours between snack and your meal time, and trying to present new foods. And then, of course, the more severe picky eating, you might need a little bit of help from a therapist, a behavioral therapist, or the moderate to severe cases. So that certainly is one of the ways to approach this, using you know, parent management techniques, and like we talked about, you know, the behavioral management of the child. And then modeling positive behavior, obviously eating your broccoli as the parent, you know, and modeling a varied diet. Also involving the child in food-related activities, so like grocery shopping, trying to make them excited about eating vegetables and different foods, and you know, maybe cooking very simple stuff with the parent, or at least watching food being prepared. Some people have talked about, you know, having like a vegetable patch and having the child watch the food be grown sometimes can help get them interested. Reading books, I put one up here, The Picky Eater by Michael Gordon. There's lots of them you can find on Amazon and other places to read with the child, that usually describe another kid who's got picky eating, just like DW in the Arthur clip I showed you. That clip is called Picky Eating on YouTube. And then, you know, using special dishes to progress to like a preferred food. Okay. So what's the longitudinal course? So what's the difference between picky eating and, we'll talk about like Arfid, like an eating disorder? So this is not an eating disorder. Certainly it's not easy to kind of tell the trajectory because the definitions were more difficult to find. It certainly wasn't in DSM, and it isn't even now. And the durations, depending on how the authors of whatever paper would define it. So it's kind of hard to compare. So for example, in Quebec, Canada, they had a 2-year longitudinal follow-up of young kids from 2.5 to 4 years. And then they found, you know, that almost 6% persisted from early childhood to late childhood. So it seems like there is some kind of subgroup that this persisted. But is that, you know, just picky eating? Does that persist as something else? Like Arfid, for example, we don't know really. We have ideas based on these studies. I'm just picking a few of them just to give you an idea. Another study in 2008 by Jacoby showed picky eating remains stable from early to late childhood as well. But that wasn't the whole sample, it was a part of the sample. And that mostly what they noticed were that there were increasing non-eating behaviors. At the time, they used the terms internalizing and externalizing a lot. Internalizing being sort of more anxiety and depression, kind of internal symptoms, and externalizing being sort of tantrums and temper and stuff like that. By the way, I put, this is another tool that sometimes some parents have used where it's almost like, you spin the wheel on this plate and it goes to a certain food, which you can then show your child. As an aside. Okay, so we don't really know the trajectory. We have some evidence to suggest to us that there are certain groups of symptoms that seem to be more stable towards late childhood in certain groups of the kids. So like the picky eaters who have more picky eating seem to have, at least according to some studies like this one from 1990, that there's a risk of more eating problems, maybe even anorexia in a subgroup of severe picky eaters. But again, there was no Arfid diagnosis. It's hard to generalize now. So what we do know is that, about a third of the kids with picky eating remitted by age 4 in one study. And that sounds like what several of these studies found. Like a good amount of these kids, it resolves sort of developmentally. A more recent study from 2020 showed trajectories of picky eating in low-income children, that the picky eating, the onset was almost always by 4 years, which is what we'd expect. And the higher amounts of picky eating were associated with a lower BMI. So maybe there's a group that does kind of have lower BMI, and perhaps, we don't know what happens longer term. It'll be interesting to see follow-up from that. All right, so picky eating, not a psychiatric disorder, no psychosocial issues, no medical or psychiatric. I mean, they can have medical psychiatric issues with it, but they certainly most of the time don't. And their growth is fine. That's like a major component. Let's move on now and expand our knowledge about Arfid, avoidant restrictive food intake disorder. That ice cream is making me hungry. Okay. So one of the reasons I wanted to talk about this is because I feel like primary care is just placed in such an amazing position. Primary care clinicians are the first often to encounter youth with symptoms of Arfid, just like they're the first to encounter picky eating. We know that the American Academy of Pediatrics suggests screening for eating disorders, and now Arfid is included as an eating disorder. Although obviously that policy came out in 2003, way before, like 10 years before Arfid was included. A survey of pediatricians, I believe they were Canadian, found that only 37% were familiar with Arfid. This was back in 2014, so I'm assuming this has changed a lot since then. And only a third correctly applied the diagnostic criteria. And what I mean by that is they're using stringent, watching if, they're checking for all the criteria that would place the child, that would exclude the child, if you will. So we'll talk about that in a minute. So at least back, 8 years ago, there was some question about familiarity. And it makes sense. I mean, primary care clinicians, I don't have to tell you, they're really busy. And so this diagnosis is not necessarily the easiest in terms of remembering the criteria, et cetera. Half of the kids with Arfid have medical and psychiatric comorbidities that can be seen in pediatric specialty offices and pediatrics as well, obviously. This was from a recent editorial in JAMA Peds. in the fall of 2021 by Grubb, and we'll talk about this was focused on a recent study by Katzman as well. So there's increasing literature, which is great because we need it to look at this in a more focused way. So we also know that decreased energy, decreased growth, it's occurring at such a critical time developmentally. So the kids who end up being in pre-adolescence, adolescence, it's not like picky eating where their growth is okay. Their growth isn't okay, oftentimes, although not necessarily. But if it is inhibited, this is an important time for the child. So it's really critical and important for their whole life, like a lot of what's done in peds, to identify this and try to act. So here's a case of Lori with her favorite foods down there in the picture. Not very healthy. So fictional Lori is a 5-year-old girl with ADHD who's on a low dose of Ritalin. She attends kindergarten, and her BMI percentile is on the lower end of her curve now. She hasn't fallen off, but it's never been high, but now it's lower. She's always been a picky eater, but then about 6 months ago, a piece of the apple she was eating got stuck in her throat. At least she felt like that. She coughed a lot. She went to see the nurse. They had to call mom, and things seemed better. She was fine medically, but then she just stopped eating apples. So that was really the only red item she ate. She ate 7 items, or mostly orange food items, Kraft mac and cheese, hamburgers of a certain type, which you can probably guess from the stylized picture, which type of hamburger that was. And that is the, and she would eat it frozen as well and heat it up. Oranges, chicken nuggets, as in the picture, baby carrots, pulp-free orange juice, I should have specified, and French fries, as in the picture. So when Lori was ill recently, she actually had a gastroenteritis or something, and she vomited after the mac and cheese, and now she's avoiding that food as well. So let's talk a little bit about Arfid, and then we'll get back to the case. So this did not just come out of, from the air, so to speak. There's been feeding disorders of infancy and childhood and eating disorders that don't quite fit other categories that have been specified in DSM, DSM-4 in particular. Those feeding disorders had to happen before age 6, and as the name implies, they mainly focus on infants and kids of younger kids. In DSM-5, around 2013-ish, they took all the literature and came up with avoidant restrictive food intake disorder, Arfid, and there's really no age restriction any longer. So this can start whenever, and it can persist into adulthood, as we know that a subgroup of people may. And there are nutritional qualifiers now, because the fear would be, I assume, that we don't want to over-diagnose people or categorize them as having, a disorder when they don't have one. So there's nutritional and functional qualifiers, so that there has to be impairment, either psychosocially, growth-wise, or nutritionally. And we'll talk about that in a minute. And unspecified eating disorder, some children or youth who may have Arfid and maybe other types of eating symptoms may fall into either unspecified, where we're not sure, sort of like the old not otherwise specified, or other specified, where we can say why, another specified eating disorder, we can say why we're thinking about that, that it doesn't quite fit, for example, Arfid. So historically, that's in a nutshell the background. Let's go over the criteria a little bit, and then we'll get back to the case I presented of Lori. So the pattern of eating, and I'm sorry for some of you, this will be a review, but I just want to make sure we're all on the same page and hit the highlights. A pattern of eating a limited variety and or amount of food, which is often associated with medical and psychiatric sequelae. So this is, like we said before, not just occasional picky eating, which is not an eating disorder. It's not due to a lack of available food. So it's not food insecurity or, that they just don't have the food, so they're not eating it. It's not motivated by a fear of weight gain, nor body image concerns, shape concerns, which would be anorexia or bulimia nervosa. So that is a number one separating characteristic from the other types of eating disorders that have weight and shape concerns. And if these symptoms are co-occurring with medical or psychiatric problems, it has to be severe enough to require attention in and of itself. So it's not just due to the irritable bowel syndrome, or the vomiting for whatever gastrointestinal reason. It's usually above and beyond that, or it's not just due to the anxiety disorder. Okay, so, and some of these, I put them here not to list DSM, but to highlight some of the exclusions. And this is what I was talking about before when they did that initial in 2014 looking at primary care. Like, some of these things aren't necessarily at the forefront of everyone's mind. So I just wanted to review them. Okay, so now in terms of the subtypes that you can see, which often overlap, of the types of symptoms that you can see in Arfid. So the first one is like a lack of interest. So this is a child who's, forgotten meals, doesn't feel full or feels full really quickly, has appetite differences, almost like the opposite of a kid who is like binge eating, where they want to eat a lot and then eat till they feel super full. This child will feel full early, not have a lot of driving, drive for the appetite, maybe some visceral hypersensitivity. They're doing a lot of research about that now to see if maybe, they have receptors in the stomach. Is it possible that those could be, having an effect in this so that they do feel fuller? But also there's the issue of just wanting to eat, and there's just less of a drive for that, it appears. So that's the first category. The second category, and again, these can overlap as we will talk about, food selectivity or sensory sensitivity. So there's a thought that perhaps these kids are super tasters, where they taste perhaps more or differently than other children. And so that leads to, being very selective about what they're going to eat. Maybe they don't like bitter tastes, or we don't really know yet. There's, again, research ongoing in this area. There's other senses, obviously. So the smell of food, the feeling of disgust, there's a lot of research now looking at, the insula area of the brain and disgust, or the feel, the texture, that some children are, don't like certain textures, particularly those who are on the autism spectrum, for example, or sensory sensitivity, whether they're on the spectrum or not, or they just have sensory sensitivities about other things that will often carry over. And you may see, sensitivities in this group. They may even, like foods of a certain color for whatever reason. That could just be preference, or it could be related to something sensory. So they have a selectivity or a specificity to the types of food that they pick, and they tend to be quite picky, for lack of a better word. And then the fear of aversive consequences is the third category. So there's a fear of something happening, like they may have had a bad experience where they thought they choked on something, like in our vignette, or they vomited while, after eating something, and then, tend to not want to eat that food. And these, as shown by the Venn diagrams, can certainly overlap. I put this here just, this is actually a slide from one of my other eating disorder talks. I just want to really visually sort of, for those who are visual learners, like really, this is like a big take home. weight and shape are not affected. This differentiates it from other eating disorders. So when you ask them, like, what do you think about your eating? They're not happy about it. They're not trying to lose weight. And they may be anxious to change it, but they don't have a problem in how they view their shape or their weight. Okay, so looking at the associated symptoms, and I just, obviously there's a growth curve of a kid who's at the lower end. So significant weight loss or failure to achieve expected growth or weight gain. That's one of the possible associated symptoms. You need one of these in DSM. 2 would be a nutritional deficiency. That's significant. So, a low iron level, a low vitamin level, something like that. Number 3, a dependence on enteral feeding or oral supplements like Boost or whatnot. 4 would be a marked interference for psychosocial functioning. And by this, it can be inability to eat with peers, inability, affecting family function so they can't eat out because this is, essentially like limited the choices so much. Or being unable to eat at school, those kind of things. Not being able to interact with peers. And again, I just wanted to mention, I know a lot of you might know this, but the slides will be available. They'll be posted, so no worries about that. Okay, and so I put on here, and in the interest of time, we're not going to go through, I'm going to start skipping through some of these a little quicker because I do want to be able to get to questions. I put on some questions that can be asked. I'll be getting to a screener in a minute, so you don't have to remember them, obviously. But, sometimes when I'm thinking about lack of interest, that, does your child forget to eat a meal? Do they just skip meals and forget? Have less of an appetite than their friends, or feel full more quickly? So that's what I think of. I put it in kind of question form. They tend to have lower BMIs according to what studies we do have. And they're a little younger than the other category of adverse consequence that we'll talk about. And again, it could be a different kind of physiology and a hypersensitivity, viscerally or somatically. And then the fear of adverse consequences, you can ask the child if they're old enough, or you can ask the parents. So that's why I put 2 different ways of asking. Do you have a fear of choking or vomiting? And you can modify it, obviously. And if you're wondering if it's an eating disorder, you can always ask if it's on purpose. In this case, I would expect not, obviously. And was there an event that occurred where the child had one of these unpleasant things happening, like choking or gagging or vomiting? And then, of course, allergic reactions can come in here. If the child had an allergic reaction, they may be fearful of having another, and you may have this kind of behavior subsequently. And then just to keep in mind, some of these kids actually do eat only certain types of food, like they'll want their green beans pureed, or they'll only eat like baby food. I mean, it's less usual, but you can see that. And then there can be comorbid anxiety or other mental health problems. And lastly, food sensitivity. So is your child, or if you're asking the child, are you, obviously that would be for an older child, sensitive to taste, like eat different foods than your friends? Or do you like foods of a certain color? Do you like foods that feel a certain way or a certain temperature, like not drinking? I know of children who only drink cold orange juice and hot and warm water out of the tap. I mean, it's very idiosyncratic. So sometimes you'll also see food rituals like the food shouldn't touch. Sometimes that'll be kids who have comorbid like OCD or not. Sometimes they may be more anxious or not. Or kids on the spectrum often don't like their food to touch. They shouldn't mix, or they have rituals or rigidity around how the food should be presented. They're more likely to reject non-preferred foods, which they're sort of extra sensitive about. And typically they've had these symptoms for a long time. And the longer they've had them and been able to sort of pick what they're going to eat and stay within, you know, under 10 types of food that they eat or whatever, it tends to reinforce that avoidance. And oftentimes here as well, you might see comorbidity, such as autism spectrum disorder, OCD, ADHD, or oppositional behavior, like extreme tantrums, stuff like that. Okay, so getting back to our person, let me just see here. So I highlighted like food sensitivity is green. So picky eater. So this girl is on Ritalin, which could certainly affect their drive to eat or whatever, but that's an external thing. So that wouldn't be part of the Arfid, but just to remember. And then being a picky eater, and then 6 months ago, there was the choking episode. So you kind of see this abrupt increase in the behavior. So there's probably some, as we'll see in a minute, sensory or other, here sensory, only likes like orange food and very picky, extreme pickiness about which foods. So this would, I would imagine, be kind of one of those kids who more, you know, if they were a picky eater when they were really young, they're part of that smaller group that persists on, that we're trying to do research about now. And then this unfortunate event happened at school where she thought she choked on something and now vomited after mac and cheese. And so now she's avoiding that food as well. So this would be Arfid. It has affected her at school as well, which I didn't put in here. So there's psychosocial, weight is influenced, and there's the 2 subtypes of, well, basically everything except loss of interest in food. Okay, the prevalence, I'm just going to skip through this, but basically it's very variable. The most recent study, which I mentioned, Katzman and JAMA Peds, they did a community-based prospective study of Arfid over 24 months. It was a Canadian study, but they found 2 in 100,000. And then you look at kind of settings where there's eating disorders and you see 23% Arfid. The globe is here because it's seen all over the world. There's Swiss schools, they found 3%. And in Australia, they found a 0.3% prevalence over 3 months. Typically you see, as opposed to other eating disorders, male equals female, or sometimes even you see even more males. And then assessments, I'm not going to belabor this. It's pretty much similar in terms of, you know, looking at the vitals and looking at the behavioral safety issues like suicidal ideation. But the nutritional indices, they find a lot of vitamin deficiencies, iron deficiencies, protein. So, you know, things like looking at those CBCs, TSH, those kind of things, and whatever you would look for, all the things you would look for malnutrition that you might find, for example, also for anorexia, might be present just by virtue of the malnutrition. Okay, here's the screen. So there are certainly lots of others. There are other screens, but they're not as short. They take longer to administer. They're more complex. This one's a nice, simple 9-item avoidant restrictive food intake disorders screen by Graff. And when this is posted, it was in Appetite, the journal Appetite, and it's available online. You can find it, or if you call BHIPP or come to our site, it'll be on the slides. But basically it says, I'm a picky eater. And then there's a Likert scale from 1 to, I don't know, like strongly disagree to strongly agree. I dislike most of the foods that other people eat, and then they answer it and get, essentially you just count the points. The list of foods that I like and will eat is shorter than the list of foods I won't eat. And so it goes on, and you just get kind of points. You can see the subscales, which are, you know, not critical, but you can basically get a sense, you know, I restrict myself to certain foods because I'm afraid that other foods will cause GI discomfort, choking, or vomiting. I eat small portions because I'm afraid of GI discomfort, choking or vomiting. So you get the idea. I'm not very interested in eating. I seem to have a smaller appetite than other people. I dislike food more than others. Okay. So that's the 9-item screen. And it just gives you, you don't have to remember which questions to screen for. And then if you add on to that, and, based on the criteria for Arfid, I, pick these out, which is also in a book, which I'll talk about in a minute. Underweight, recent weight loss, stunted growth, yes or no. Nutritional deficiency, yes or no. Dependent. So these are the 4 items that I reviewed earlier. Dependence on supplements and difficulty with social situations. So you need one of these essentially to know that this is really affecting them. So you really just want one of these to be yes. And then that gives you an idea that there may be Arfid. I would still say, that would be a red flag to refer for more screening or to maybe send them to a therapist, but we'll talk about that in a couple of minutes. Differential, we talked basically about all of these. Comorbid psychiatric illnesses, sometimes if they were mild, might be presenting with this food symptom. So remember that. It can be the next step, perhaps. We don't really know, to the extreme picky eaters. And we need to rule that out, that it isn't just picky eating based on the weight and the how they're doing physically in terms of their growth, and also, again, the eating disorders. Make sure that there's no weight or shape issues. In terms of psychiatric comorbidity, up to 40% of kids in some studies have had comorbid psychiatric diagnoses. So screen for ADHD, anxiety. There was one study that found that anxiety is the #1 comorbidity. But you can certainly have anxiety, all the stuff we talked about, obsessional thinking or rituals, autism, rigidity, social impairments, or other neuropsychiatric disorders, having ritualistic eating, and any history of developmental not hitting their milestones might be kind of red flags to remember. And here you have salmon in 2 different ways, and the therapist may be presenting this plate to a child, trying to get them to eat a food in a different way, or maybe they only eat the food in that way. And as you see here, this would be a great plate for children I've seen who don't like to have the food touching. Okay, we talked about this. I'm not going to go over this. I'll just say a longer duration of picky eating or a history of picky eating, again, can reinforce that avoidance. And any new symptoms, just like with any eating disorder, is in need of making sure that there's no underlying organic or medical issue that might have now declared itself, obviously, which I don't need to tell this group who's like super duper pediatricians and primary care providers. So I summarized some of the stuff we already talked about. We're going to move on to treatment in the few minutes we have left. I like to, the ones that I italicized here, what reason does the youth give for not eating? To again, make sure, that it isn't a shape or weight concern. And what does the youth think about the weight loss? And sometimes I'll ask about a fear of new foods, which we call neophobia. All right. So last but not least, there is not all that much known about the management, but I'm going to just pick some highlights. There's a lot of research going on now, so that's very, very positive. And in the future, we will be seeing lots of exciting developments. So again, like with any eating disorders, the pediatricians have an essential role to play as part of the team, particularly like when you're talking about an outpatient team, which a lot of the time you are, especially early in the progression of the illness, when they're not as malnourished or in need of an inpatient treatment. So with the parents, getting them on board, just like with any other eating disorder, to explore any concerns of the parent, refer to nutritionists, a therapist with eating disordered experience, preferably Arfid, maybe a psychiatrist if there's comorbidities. And for sensory subtypes, perhaps consider an occupational therapist if the therapist agrees to try to, get them to eat foods with different textures or new foods. For any, this slide I use on every talk practically. Any mental health issue, always consider the level of care, how much you're concerned about how they're progressing, and are they really malnourished? Are they really low weight? Then you might think kind of less outpatient, more intensive outpatient day hospital, or even inpatient medical or psychiatric, depending what the patient needs. And again, these are very similar to the anorexia literature. I mean, you're really looking at malnutrition and the body that just has deficits in terms of hydration and medical concerns, which I'll defer to you all. Growth, if the growth is severely affected, or the weight loss, or acute changes. And psychiatric safety, you might think about admitting if they've become suicidal. Sometimes there just isn't, they're very serotonin and other neurotransmitters and proteins are depleted, and they just get very apathetic. And sometimes you see obsessionality, ritual, suicidal thinking. Okay, so those are kind of when you would think of a higher level of care. And nutritional referrals, this is just an idea of, with fuller subthreshold, like not quite fitting criteria for Arfid, you can see that fruits and vegetables are the groups of the less preferred foods. Nutritional refeeding, usually they focus on the weight if they're underweight first, and then on the variety. And depending on the medical comorbidities, they might have, other needs as well. So this is the book. This book is really geared more towards the actual patient, which now can go into adulthood, as we talked about. But this book by Thomas and Becker and Eddie, they're from Harvard, is really great. It actually has the screener that I showed you, a version of it, and talks about how one can rate oneself, which is really, really nice. And it summarizes some of the cognitive behavioral techniques that can be used by the family or the patient, talking about eating regularly, stuff we've talked about before for eating disorders and for Arfid specifically as well. So weight restoration if underweight, and then increasing the variety. And so this is a really good self-help book. We'll talk about the meds in a minute. There's not much to talk about because we're running out of time, and because there isn't that much known as well. This is just the two, I'm just going to highlight them really, really quickly: family-based treatment and cognitive behavioral therapy, both for Arfid. And the CBT can be family-based or individual. The individual is more of an older adolescent or adult, or not very underweight. So most of this is family related, which makes sense, right? The evidence is not as great as we have for FBT or family-based therapy with adults or adolescents with anorexia, but we're having some pilot work being done, and there are studies on the way. So this is the book that just came out, actually, Family-Based Treatment for Arfid, and it's a lot of the same phases. It's based on anorexia nervosa FBT, and I'm not going to go through it. It has the 3 phases, and then we talk about family-based because they eat together, and you can go through these slides. Basically, it's helping enable the parents, basically. And they also focus on some of the subgroups of symptoms as well, which is beyond the scope of this talk, but it's an excellent book. And you see that the focus is not on blame or causation, but on symptoms, and it enables the caregiver and also keeps in mind warning symptoms. The other therapy that is really, this book is a really great book. These are workbooks, essentially. There are pilot studies. These are by very well-known eating disordered researchers. So the other one was James Locke, and this one is Thomas and Eddie, the same group of people who wrote that picky eating self-help book. This talks about 20 to 30 sessions over 4 stages, and then the 2 forms of cognitive behavioral therapy for Arfids. And once you reach stage 3, there are modules as to the type of Arfid you're looking at. So I took this is just a copy of the just like the other book. This is just the cover. And then this is from that you see the 4 stages. What does CBT, Arfid, AR look like in the 4 stages? And it goes through sort of psychoed, early changes, increased volume, then variety. Face your fears, exposure, and then wrapping up prevention of relapse. And there's again pilot studies that have been done, and so it'll be exciting to see what the larger studies will show. But these are really good books for therapists to follow and to help get ideas. Unfortunately, there isn't much more out there. And we're really lucky that those books have come out now. I know I'm running behind. This is the last thing I'm gonna talk about is what about meds? So like most eating disorders, there isn't that much that we do know. And I think it's the problems enhanced for Arfid because it is so new in terms of having the stringent diagnostic criteria that would allow us to really look at medications. So, more of the studies, we do have a little bit more evidence as for many eating disorders, more evidence for the therapies right now. There are retrospective case series or reports for some of these meds that I've listed. Mirtazapine or Remeron, I mean, there's just not a lot of data for Remeron in kids, and I certainly, personally typically do not use in little kids, but a very experienced eating disorder focused group tried this for 14 kids, went up to 25 milligrams and felt that, this helped. So there is some data, although it's certainly not a randomized controlled trial. There aren't any. So this is one idea. If you had a very severe sort of kid, this would be kind of one thing that's out there in the literature. And again, I'm not trying to direct treatment. I'm just going ahead and listing the very few things that we do know about meds. So in the older days, when it was a feeding disorder, people used cyproheptadine a lot to increase appetite. It's an antihistamine. I think pediatricians know probably more than child psychiatrists about this, given that it was used a lot in the feeding sort of pediatric realm. And this, sometimes some people say as you use it, it stops working. It's to increase appetite. So it would be for that specific subgroup. Olanzapine, there's been initial studies looking at how that would work for satiety. I would not recommend this at this point, but just to know that this is out there. And then there's a newer study from October in the JCAP, the Psychopharm Journal for child psychiatry, SSRIs with or without hydroxyzine, again with an antihistamine type effect. That may help. And then I think the most important medication take home is, like for any other eating disorder, treat the comorbid psychiatric illness and symptoms. And of course, know that when they're very malnourished, meds just don't work very well. So it's refeeding them to a weight where they are not so malnourished. Okay, so take homes. Primary cares have a really important role to play. I don't think I have to convince you of that. The trajectory is variable, but there may be a subgroup where it persists. Making sure everyone's safe medically, they may need refeeding or whatever, and making sure psychiatrically that they're safe, and knowing that there are these 2 manualized treatments that are available. Research is ongoing, both for therapy and for the medication, for any medication use. But the therapies are based on very well established therapies for other eating disorders and in kids as well. And then always keep in mind the comorbidity. All right, questions. Sorry, I think I ran over.
Thank you so much for that, Dr. Reinblatt. We do have a few questions, and if others have questions, go ahead and feel free to put those either in the chat or the Q&A, whatever is easier for you. But I'll start with the questions we do have. This first one here is, do you routinely recommend those labs that you listed, especially for those parents that ask to have their kids tested for nutritional deficiency?
I mean, I don't know that it's easy to routinely recommend stuff when there's no data, really. I mean, on a case-by-case basis, if someone's severely like underweight and the parents want it, could you? Yes, I mean, it is part of the workup, but I just put them out there so you could think about them. Obviously use your clinical judgment. I certainly wouldn't do them routinely for everybody. As data emerges, maybe we will be, but right now I think there's just sparse data out there. So if you're thinking about it and the parents want it and you feel like you want to do it, go ahead, use your clinical judgment. But it's just to know that those are things to consider.
We have another question about the labs, specifically about how to get insurance to pay for them and with medical insistence.
So, I mean, I think most of those labs, I was thinking more, if you have a kid who's, very low weight and you're concerned about them, then that would be when you would think of it. So like taking it very on a case by case basis. And I think most of the insurance companies, if you have a clinical reason for something, I mean, typically one would hope that you could argue the concern. I know it's sometimes very hard. And if there's any other medical stuff going on, you can sometimes partner it into that or with the medical, whatever else you're looking at. But I know it's something challenging, so I don't really have a good answer.
Okay, thank you. And another question here about why cholesterol levels would be elevated in anorexia.
That's a really good question. Well, these are all great questions. So cholesterol is made in the liver, and sometimes you also have liver enzymes that go up in the liver. It has to do with like starvation and malnutrition. And unfortunately, it's way beyond my focus and expertise as a child psychiatrist. So I don't know exactly why, but you do see in malnutrition and low weight, like starvation, you see the cholesterol go up. I don't really know the mechanism other than, like I say, there is something going on in the liver that increases the liver, especially even before you refeed, but particularly as you're refeeding. So I would have to look up the mechanism for that. Sorry. It's a great question, though.
Well, thank you, Dr. Reinblatt. Oh, we do have, let me just make sure there's no more questions. I don't see any more questions as of right now. Thank you so much for sharing your expertise with us here today. We really appreciate it. I'm sure the audience appreciates it as well. There will be a survey as soon as everyone closes out. So if you could take the moment to fill that out, we'll get those CEs and CMEs out in 3 business days. And the slides will be on our website as well as the recording for the presentation today. But thank you everyone for joining us.
Thanks.
Thank you.